All right, welcome. In this masterclass, we are diving deep into the powerful world of anticoagulants and thrombolytics. These are the drugs that give us incredible control over blood clotting. Understanding how they work is absolutely crucial for both preventing and treating dangerous clots, or thrombosis. So let's get right into it.
So, here's our game plan. First, we're going to start with the basics, the beautiful, delicate balance of how our blood naturally forms and dissolves clots. Then, we'll journey through the major drug classes. We'll look at the injectable, or parenteral anticoagulants like heparin. Then we'll cover the classic oral drug, warfarin. After that, we'll get into the newer agents, the NOACs. And finally, we'll wrap up with the really powerful clot-busting drugs, the fibrinolytics.
Okay, first things first. Before we can talk about the drugs, we have to get grounded in the biology. It makes sense, right? To really understand how these medicines work, we first need a solid grasp of the natural systems they are designed to manipulate. And those two systems are coagulation, which is just the process of forming a clot, and fibrinolysis, the process of breaking one down.
Now take a look at this. This diagram really gets to the heart of the matter. You can see there are two starting points, two initial pathways. They're called the intrinsic and the extrinsic pathways. And what do? Well, they both converge to activate a super important player called factor X. The whole point of this entire complex cascade is to generate an enzyme called thrombin. And thrombin does the most important job of all. It takes a soluble protein that's just floating around in your blood called fibrinogen, and it converts it into these insoluble strands of fibrin. You can think of it like turning liquid glue into solid threads that then weave together to form a mesh, and that's your clot.
So let's break down the key components of this system. This isn't just one simple chemical reaction. It's a true cascade, like a domino effect of enzymes we call clotting factors. These factors, which are numbered I all the way through 13, need calcium to get going. That's a non-negotiable. Normally, they're just circulating in your blood in an inactive form, what we call a proenzyme. So for example, factor X gets cleaved and turns into the active factor XA. The A stands for active. Now here's a really crucial point, vitamin K. The liver absolutely needs vitamin K to produce some of the most important factors, I, V, II, IX, and X. And of course, to keep this incredibly powerful system from going haywire and clotting everything, the body has its own natural brakes, or inhibitors, like antithrombin 3 and protein C and S.
So, the body is an expert at building a clot. But how does it get rid of it once the job is done? Well, that's where fibrinolysis comes in. This diagram illustrates the process perfectly. The cells that line our blood vessels, the endothelial cells, release a substance called tissue plasminogen activator, or TPA for short. If you follow the arrows here, you can see how TPA finds this inactive protein called plasminogen and activates it, turning it into plasmin. And plasmin? Plasmin is like a pair of molecular scissors. It goes to work chopping up that fibrin mesh, dissolving the clot.
And just like the clotting system, the clot dissolving system has its own set of brakes to make sure it doesn't get out of control and dissolve clots that we actually need. You've got PAI1 and PAI2, which are plasminogen activator inhibitors. They do exactly what their name says. They block TPA, so less plasmin gets made. Then there's another molecule, alpha-2 antiplasmin, which goes after plasmin itself, inhibiting it directly. It is all about maintaining that perfect balance.
This brings us to the vascular endothelium, that inner lining of our blood vessels. It plays this absolutely fascinating dual role. In its normal, default, antithrombotic state, it's actively preventing clots. It uses molecules like heparin sulfate and prostacyclin to stop platelets from clumping up, and it releases TPA. But when it gets injured, it's like a switch flips. It goes into a prothrombotic state, releasing things like von Willebrand factor and tissue factor to kickstart the whole clotting process. It's an incredibly dynamic surface that's constantly managing this balance between bleeding and clotting.
All right, now that we've got the foundational biology down, let's move into our first class of drugs, the parenteral anticoagulants. And parenteral is just a fancy way of saying they aren't taken by mouth. They're given by injection or infusion. And we're going to start with the most famous one of them all, heparin.
So, what's the main job of anticoagulants? Well, their sweet spot is preventing the formation or the extension of a thrombus, especially in the venous system. Think of a deep vein thrombosis, a DVT. The reason for this, as the slide explains, is that venous clots, which form in slower-moving blood, are super rich in fibrin. They're basically a big mesh of fibrin with red blood cells trapped inside, which is the exact thing these drugs are designed to prevent. They're not quite as good for arterial clots, which form in fast-flowing blood and are made mostly of platelets.
Now, heparin actually comes in two main flavors, which you can see compared side by side here: unfractionated heparin, or UFH, and low molecular weight heparin, or LMWH. And they have some really big differences. UFH is the larger molecule and typically has to be given as a continuous IV infusion in the hospital. LMWH, on the other hand, is made of smaller molecules. It can be given as a simple subcutaneous injection, kind of like an insulin shot. It has way better bioavailability, about 90% versus 30%, meaning more of the drug actually gets into your system, and it has a longer half-life.
This slide right here perfectly explains why their actions are different, and it all comes down to size. Both types of heparin work by basically supercharging that natural inhibitor we talked about earlier, antithrombin 3. But here's the crucial part. To inhibit thrombin, the big UFH molecule has to be long enough to grab onto both antithrombin 3 and thrombin at the same time. It acts like a bridge connecting the two. The smaller LMWH molecules, they're just too short to do that. So they primarily just bind to antithrombin 3, which is all that's needed to specifically shut down factor XA.
Okay, let's talk risks. The most common side effect is, unsurprisingly, bleeding or hemorrhage. But there's a much more complex and dangerous one called heparin-induced thrombocytopenia, or HIT. This is a bizarre immune reaction where the body makes antibodies against heparin when it's bound to a platelet protein. This creates a paradox. The immune system starts clearing out platelets from the blood, causing low platelet counts, but it also activates the remaining ones, which can cause dangerous new clots. The risk is much higher with UHF. Thankfully, we have a specific antidote, protamine sulfate. It's a positively charged protein that basically latches onto the negatively charged heparin and neutralizes it.
So, what happens if a patient develops HIT and can't take heparin? Well, we have alternatives. As this table shows, drugs like argatroban and bibalirudin are direct thrombin inhibitors. They block thrombin directly without needing any help from antithrombin 3. Then you have fondaparinux, which is a synthetic molecule that is extremely selective for factor XA, and it has a much lower risk of causing HIT. The main takeaway here is that these are often the go-to drugs for patients who have that dangerous reaction to heparin.
We're now shifting gears, moving away from injectables and onto the classic oral anticoagulant that's been around for decades, warfarin. And as we're about to see, its mechanism of action is completely different from heparin's.
This slide is the absolute key to understanding how warfarin works. Remember how we said the liver needs vitamin K to make factors 2, 7, 9, and 10? Well, to be more specific, it needs the active, reduced form of vitamin K. In the process of making those clotting factors, vitamin K gets used up. It becomes oxidized. So the body has this great recycling system. It uses an enzyme called VKORC1 to recycle that used up, oxidized vitamin K back into its active form so it can be used again. Warfarin works by blocking that exact enzyme, VKORC1. It shuts down the recycling plant. The body can't recycle its vitamin K, so it runs out of the active form, and the production of those key clotting factors just grinds to a halt.
This mechanism explains all of warfarin's key features. Because it only stops the production of new clotting factors, it has a very slow onset of action. As the slide notes, it takes a good 3 to 4 days for the body to simply use up the factors that were already floating around in the blood before the drug was started. It's also metabolized by a highly variable enzyme and has a very narrow therapeutic window. That means the line between a dose that works and a dose that's dangerous is very, very thin. And that is precisely why it requires such frequent blood monitoring with a test called the INRI, or International Normalized Ratio.
And the whole point of all that monitoring is to get the blood to just the right level of thinness. For most conditions, the target INR is a value between 2 and 3. Once you get an INR above 4, the risk of a serious bleed goes up dramatically.
Now, one of the biggest challenges with warfarin is its massive number of interactions. So many things can enhance its effect and increase the risk of bleeding. For example, NSAIDs can knock warfarin off the proteins that carry it in the blood, which increases the amount of free active drug. Broad-spectrum antibiotics can wipe out the bacteria in your gut that actually produce vitamin K. And then there's a whole list of drugs that inhibit the CYP450 enzymes that break down warfarin, causing its levels in the blood to rise. And then you have the flip side. Other things can diminish warfarin's effect, which increases the risk of clotting. Some drugs are CYP450 times inducers. They speed up the enzymes that metabolize warfarin, causing it to be cleared from the body faster. The herbal medicine St. John's wort is a classic example of this. And of course, since warfarin works by blocking vitamin K, if you start consuming a lot more vitamin K in your diet or in supplements, you're going to directly counteract what the drug is trying to do. All of this complexity with warfarin is really what led to the development of a whole new generation of drugs.
So let's move into our fourth section, the novel oral anticoagulants, or NOACs. You might also hear them called direct oral anticoagulants, or DOACs.
This comparison table really just says it all, doesn't it? Look at the difference. Compared to warfarin's slow onset of several days, NOACs get to work within just a few hours. They have far fewer interactions with food and other drugs. And they have a much broader therapeutic window, which is the key reason why routine blood monitoring, like the INR test, is not required. It was a massive leap forward in terms of convenience and predictability.
NOACs fall into two main classes. First, you have the direct thrombin inhibitors, and dabigatran is the main example there. The second and more common class are the factor XA inhibitors, like apixaban and rivaroxaban. What's really fantastic is that we now have specific, highly targeted antidotes or reversal agents for these drugs. For dabigatran, there's a monoclonal antibody called idaruzumab. And for the factor XA inhibitors, we have andexanet alpha, which is this incredible molecule that acts like a decoy to soak up the drug from the bloodstream.
Now here's a really important point that people often misunderstand. When we say no routine monitoring, that does not mean zero monitoring. That's not true. These drugs are cleared from the body by the kidneys, so renal function has to be checked at least once a year. And of course, doctors and nurses must always be assessing their patients for any signs of bleeding or other risk factors. So while the weekly or monthly INR checks are gone, careful clinical monitoring is still absolutely essential. This brings us to our final category of drugs, and these are fundamentally different from everything we've talked about so far. Anticoagulants are all about preventing clots from forming or getting bigger. Fibrinolytics, also called thrombolytics, do something else entirely. They actively dissolve clots that already exist. These are the true clot busters. Their mechanism of action is actually beautifully simple. They tap directly into the body's own clot-dissolving system that we looked at in the beginning. These drugs are essentially turbocharged activators of plasminogen. By converting massive amounts of plasminogen into the active enzyme plasmin, they unleash this incredibly powerful fibrin-degrading force that can just break down an existing thrombus and hopefully restore blood flow.
There are a couple of main agents in this class. The older one is called streptokinase, and it's actually derived from bacteria. A big downside to that is that it's antigenic, which means the body can form antibodies against it, which often prevents it from being used more than once. The newer agent, alteplase, is a recombinant, man-made version of our own human TPA. So it isn't antigenic, and it's also more fibrin-specific, meaning it prefers to work right at the site of the clot. But, and this is a big but, the major risk for both of these drugs is still hemorrhage. So let's try to put this all together in a practical way. This slide gives a great summary of which drugs are typically used for which conditions. For stroke prevention in someone with atrial fibrillation, a NOAC or warfarin is standard care. For treating a DVT or a pulmonary embolism, or PE, you have a wider range of options. For patients with mechanical heart valves, warfarin is still the king. It's the mainstay of therapy. And this last one is critical. For treating a DVT during pregnancy, you can only use injectable anticoagulants, like LMWH. That's because warfarin can cross the placenta and cause birth defects, so it's a definite no-go.
And that brings us to the end of our masterclass. We've really covered a lot of ground, from the basic coagulation cascade all the way to the most advanced therapeutics. And it kind of leaves us with this one final fascinating thought. We've gone from these relatively blunt instruments to these highly specific, direct-acting agents that even have their own targeted antidotes. So the big question for the future is, as our understanding gets deeper and our drugs become even more sophisticated, will we one day achieve the holy grail of this field? The ability to dissolve a dangerous clot with absolutely zero bleeding risk? Only time is going to tell.